Hi, I'm Taylor.
And I'm Catherine, and our presentation today is on hyponatremia. Hyponatremia is defined as a blood sodium level of less than 135. This can happen in two ways. It can happen by consuming too much water or sweating out too much sodium. This is prevalent in two different populations, the athletes as well as the elderly population. Now, hyponatremia is important to all of us because 25% of Gettysburg College students are D3 athletes. And this means that a large portion of our population here can experience this, as well as just people that work out on a daily basis. So consuming too much water is the primary cause of hyponatremia, and that's why it's important to have proper information as far as the elderly and athletes in the consumption of water. So our presentation today is about the physiological causes, the risk factors, the treatment, and the prevention of hyponatremia.
So for this presentation, it's important to understand the water definitions and just how it moves within the body. So for this, we have hypertonic, isotonic, and hypotonic conditions. So in hypertonic, the water is going to move out of the cell, making the cell light. And this is because a solution has a higher solution concentration than another solution. In isotonic, the solution concentrations are going to be the same. So there's going to be no net movement of water into or out of the cell. It's going to remain neutral. And then hypotonic, this is when water is going to move into the cell and ultimately cause the cell to expand and become bigger. And this is because due to a solution has a lower solute concentration than another solution. So these are going to be important to understand the different classifications that we're going to talk about later on in this presentation.
So another really important thing to note in hyponatremia is the production of arginine vasopressin hormone, which for right now we'll call AVP. AVP is the same thing as antidiuretic hormone, and we've learned about that in class as well as in past classes. So AVP is secreted by the hypothalamus, and the hypothalamus is inhibited by the pituitary, and the pituitary inhibition can be overridden by exercise or old age. When this override occurs, it will cause an increase in aquaporins in the distal convoluted tubule and the collecting duct of the kidneys. But when the body has retained enough water, the override will stop and the AVP secretion will be inhibited again. However, in extreme athletics, it has been found that there is a non-osmolaric secretion of AVP, and this happens when the baroreceptors in the blood, in the endothelial cells of the blood vessels are triggered, and it is not really known why yet, but these baroreceptors trigger the uninhibition of the hypothalamus, causing a secretion of AVP and an increase in water retention, causing an increased dilution of sodium in the plasma.
So physiology of water balance, which is basically what hyponatremia is when on daily basis, the body has different intakes of water and sodium, and this ranges all the time between each day and activities that you're doing. But in healthy humans, the plasma sodium concentration is going to stay within a narrow range because the body has this mechanism creating homeostasis. So it can keep it between 1 to 2% of the baseline and keep you healthy and not cause any problems. And the plasma osmolality is regulated through two ways, and this is through AVP, which we just talked about, and through thirst. So basically, these two work together, and when they detect change, then that is when they're stimulated. So if there's a rise in the plasma osmolality, and this is when there's stimulation and synthesis of AVP to enable the reabsorption of water from urine to the blood at the same time that the third center and the cerebral cortex is making you drink, so there's going to be a higher intake of water. And then these two mechanisms lead to an increased plasma water and normalization of the plasma osmolality. And then these changes are ultimately reflecting that hyponatremia is a disturbance of water balance and not necessarily the dysregulation of sodium excretion or like sodium intake. So basically for hyponatremia, it's about how the water is being maintained in the body.
So as stated before, hyponatremia is caused by two different things: consuming too much water as well as sweating out too much sodium. So this is about consuming too much water. When we consume too much water, there is an excess fluid intake, and this excess fluid intake can cause an increase in ABP secretion, as we stated, and then this causes an increase in sympathetic nervous system and an increase in the renin-angiotensin-aldosterone system, which we also spoke about in class. This trigger of the sympathetic nervous system causes an increased absorption of fluids, and there's water release from glucose storage, and this all leads to an increased dilution of sodium levels in the plasma, and this causes hyponatremia. The other cause of hyponatremia is sweating out too much sodium. By sweating out too much sodium, we are decreasing the amount of sodium in our plasma. Now, the amount of sodium in your sweat varies from individual to individual. People who have cystic fibrosis usually are salty sweaters, as we learned in class, and that just means that they're at an increased risk for hyponatremia. And this all, like I said, varies from person to person.
So there are three main ways to classify the hyponatremia and water balance in the body. First is hypotonic, and this has three subcategories of hypovolemic, euvolemic, and hypervolemic. And there's pseudohyponatremia and non-hypotonic hyponatremia or hypertonic hyponatremia. So for hypotonic hyponatremia, all of these are just based on the water volume in the body or the extracellular fluid volume. So for the first one, hypovolemic, this is depletion of both water and body sodium, but has an excess loss of sodium. So this can be through renal or non-renal, and the leading drug induced hyponatremia is from thiazide, and this is more prominent with elders, people with low body masses, and females. So basically what thiazide is, it is a FDA-approved drug, and it inhibits 3 to 5% of reabsorption of sodium in the luminal in the nephron, and it blocks the sodium chloride channel, so it decreases levels of sodium across the membrane, and then thus it decreases the sodium and potassium pump and decreasing sodium and water into the interstitium. And then euvolemic is not due to depletion of water, but caused by a relative increase in body water. So this is from two main things, mostly from syndrome of inappropriate antidiuresis, SIAD, or from adrenocorticotropic hormone, ACTH. So for SIAD, people with SIAD, they don't really have a regulator to tell them to stop drinking because of inhibitory effect of osmoregulated thirst. So it's not sufficient enough to stop their behavior, so they keep drinking and drinking, so this increases the amount of body water that they have. And then ACTH works in a similar way physiologically, but in this sense, it just it minimizes the use of cortisol, and without cortisol, you cannot take on the role of free water excretion. And lastly, hypervolemic, increase in both total body water and total body sodium, but an excess of total body water, and this is also just coined as dilutional hyponatremia because of all the water coming in.
So pseudohyponatremia is classified as artificial hyponatremia, and it is water is equal to 32% of the serum volume, whereas 7% of the serum volume is non-aqueous components, mainly lipids and proteins. And what occurs here is that there's an increase in proteins and lipids, as you can see right here, compared to the normal, and where it takes up more of the plasma volume, which just decreases plasma volume in total together. And this was found in this article, an exaggeration physiological dilution of plasma sodium by non-aqueous materials.
So then final is non-hypotonic hyponatremia, or also you could just call it hypertonic hyponatremia. So this can occur from hypoglycemia, or when a normal or increased osmolality occurs when there are extra osmoles in the serum. So when this happens, it decreases serum sodium concentration by attracting water from the intercellular compartments, and then hyperglycemia is the main cause because of these osmoles attracting the water from the interstitial compartments, so then the dilution of the serum sodium levels. And when lowering the plasma glucose, when you're trying to raise this back up to the normal levels, it's important to do it at a controlled rate so that you cut down the risk of cerebral edema, because that can lead to even more complications, as we'll see later, complications from hyponatremia. So yeah, hyperglycemia and the osmotic shift can lead to hypertonic. So risk factors, this is going to depend on what classification you're on. It's also maybe the inability of the kidney to excrete enough water to keep the level of water and sodium balanced. So all classifications, they have their own things. As you can see on the board, there's a bunch. As I already said, for the pseudo hyponatremia and the hypertonic hyponatremia, they have the causes of SID, proteins for pseudo, and then for hypovolemic, these are for the hypotonic hyponatremia. These are the causes. So for hypo, as I said, it's low from both the loss of water and from sodium, but it causes from gastrointestinal, but more sodium loss. So this is from gastrointestinal fluid losses such as diarrhea or vomiting, excessive sweating, because diuretics because it makes you excrete more water, cerebral salt wasting syndrome or mineralocorticoid deficiency. Hypervolemic, as I said before, it's from an increased total body water and sodium but more water. So these can be from renal causes such as acute renal failure or chronic renal failure, nephrotic syndrome, or extrarenal causes such as congestive heart failure, cirrhosis, or iatrogenic. So when cirrhosis happens, this is impairment to the renal capacity to eliminate solute-free water because it causes retention of water causes inappropriate water retention compared to the sodium. So this is a reduction in serum sodium. And then the euvolemic, as I said before, SIDH, or there's Addison's disease, and this is because Addison's disease, it damages the glands that are on top of the kidneys, so there can't be water retention from the kidneys. Like it's supposed to be doing hypothyroidism, high fluid intake, medical testing related tests, like as colonoscopy, because they make you drink lots of fluids before the test to do it done correctly. Or from a number of drugs such as vasopressin analogs, thiazide, as I said earlier, or ecstasy, because with ecstasy there's high fluid intakes and an inappropriate stimulation of ABP.
So signs and symptoms vary greatly on the individual as well as the amount of sodium that is lost. So as we stated, there are different types of hyponatremia, and there's also different amounts of sodium lost. So hyponatremia, again, is sodium serum levels less than 135. So between 135 and 130, we have an asymptomatic person. This asymptomatic person can be in more danger than we realize, because if you don't know that you have hyponatremia, you might not be treating it with intaking more sodium or getting the necessary treatment from doctors. Whereas that can continue on to be a serious serum sodium levels of 130 to 125. From here, we start to see symptoms like dizziness, nausea, lightheadedness, and fatigue. And these are obviously very uncomfortable feelings, but they're also not unlike feelings of dehydration. So the first thing that we realize when we start to feel bad, we instantly think that we're dehydrated, and it happens to a lot of people. But in reality, it could be similar symptoms to hyponatremia, And this is why it's very important for education, but we will also get to there later in our presentation. But and then serum sodium levels of less than 120 to 115 can cause seizures, coma, and even death. You're usually disoriented. People are usually getting pretty uncomfortable and lethargic, and can cause a lot of issues. Like we said, serum sodium levels dropping below 115 can cause some pretty severe psychological as well as physiological issues, and can lead to death in severe situations. So this is all the symptoms of it, and you can originally see this when this is originally an issue because of the gradient difference. When there's a increased difference in gradient, more water will rush into the cells, causing edema, and there's an increased pressure, and that is what causes the psychological symptoms on the brain.
So for treatment, it's really important that you understand what you're being treated for. So doctors and trainers, they really have to understand the main causes for these, the main signs and symptoms to be able to diagnose it correctly. It's really important to be able to know if it's hyponatremia or if it's dehydration, because they do have the same symptoms. So if someone mistreats you and say you're actually hyponatremic, but they say that you're dehydrated, and then they're going to treat you with more water to get you hydrated again, then this is going to be bad, because then your cells are going to become even more, you're going to have even more diluted plasma sodium levels, and that's just going to add on to the effect that you already have with hyponatremia and cause greater effects. So treatment does depend on the type of hyponatremia. So with hypovolemic, this is just going to be treated with the basic saline 9% sodium to restore the ECF, and saline helps to work on both the sodium and water levels and brings them both back in. Euvolemic, you're going to want to measure the urine sodium and urine osmolality to see if it's a problem with the ABP or with just how much water that you have in. So by testing the urine concentration, you can see underlying problems behind this. And then treatment for this is just fluid restriction to ease back on the water volume that you're taking in, and then to get it back to normal. And then hypervolemic, this is going to just be fluid and sodium restriction, so that you're cutting back on both of these so they can't add on. So yeah, basically just treatments are to stop the intake of the fluid, the problems that you're having. Oh. And then exercise-associated hyponatremia, as Catherine already said earlier, it's obviously common to everyone in their everyday life, especially for athletes. Just going to the gym can be very important to understand how your body works and to listen to your body. And it's very prevalent in endurance runners, like marathon runners. So this is just a decrease in sodium levels, and it doesn't have to happen right away or during the event. It can actually happen up to 24 hours after the event has happened, so it has prolonged and just long time for these symptoms to come about. So it can be go unnoticed for a long time before you feel these symptoms. So basically, the human body isn't designed to regulate body weight when we're working out, but athletes are normally just scared to drinking too much water before endurance events, because they want to be able to match the sweat rate that they're having during the events, and to work on and to not lose body weight, because these can ultimately decrease their ability to perform during the events. But it's also been proven that the hyperhydration that they're taking on before these events can actually lead to impaired performance, so they're not going to perform as well as they hope they were going to before. And then the hyperhydration leads to problems like hyponatremia, which can lead to very bad consequences, like we've seen before when we talked about. So when they do get exercise-associated hyponatremia, they become confused and typically lose consciousness or become withdrawn. So when they're withdrawn, they typically go into fetal position, don't want to talk to anyone. And then later on, they become slow and dull because brains have swollen and not functioning normally. So we see that it actually has central nervous system impairments, so that it leads to even more complications than just the ones that we talked about, and as Catherine said, like coma or death could actually be prevalent from this. So basically, from exercise-associated hyponatremia, you just have to be able to know how your body's going to work and don't be hyperhydrating, because that's actually how it's going to be caused. So you just want to drink during the event, and it's actually been proven that having sodium intake during the events is not going to help you at all, because the factors are already onsetted. So once it's happening, there's really no correction for it during it by sodium. So you just kind of have to go through the trainer and the saline or just fluid restrictions as seen. So you just want to be careful when you're exercising that you're not overdoing it, not on your body, but just drinking, as you don't want to have these complications.
So Taylor just alluded a little bit, but prevention is the main thing that we want to occur. The main way to have prevention is through education. So if we educate athletes as well as the elderly about the issues with overhydrating, then we may be able to decrease the amount of emergency room check-ins and ICUs that people have to be checked into. A study was done, and it was labeled "Are we being drowned by overhydration advice on the internet?" And this study basically looked at a whole bunch of different search engines such as Google, Bing, and Yahoo. And it searched things like hydration guidelines, hydration with exercise, and drinking guidelines. And what it found was that there is so much misinformation about drinking and hydration on the internet. For example, of 106 searches, only 10% of those had stated that electrolyte intake during exercise is not necessary. So as we spoke in class, athletes don't necessarily need to have Powerade and Gatorade while they're exercising, because you're not losing that much electrolytes when you sweat. But only 10% of 106 articles stated this, as well as only 3% of 58 websites said that dehydration is not generally a cause of heat illness. And so this just emphasizes the importance of misinformation on the internet, which is why we really need to have an intervention, reaching out to communities as well as coaches and athletes about the severity of hyponatremia and the severity of overhydration. So next, we have the importance of thirst. And as Taylor talked about before, the importance of thirst is extremely important, because thirst is a biological thing that was set in place for us to know when we need to consume water and when we don't need to consume water. So if we listen to our thirst triggers, then that will tell us when we need to drink water. So if you're an athlete and you're drinking water, excessive amounts of water before your race or after your race, and you're not thirsty, that may lead to the fact that you are consuming too much water and don't have enough sodium serum concentration. And basically the whole point is just listen to your body and listen to what you think you need. So the last thing we have is new research. So there are two new research mechanisms brought out. There's rhabdomyolysis, and rhabdomyolysis we learned in class, and it is the breakdown of muscle cells. And this muscle cell breakdown releases toxins, and it also releases myoglobin into the bloodstream, and this can go into the kidneys and can cause a poisonous and deadly effect. So hyponatremia can cause rhabdomyolysis, and rhabdomyolysis can cause hyponatremia. This can happen when we have intracellular plasma and calcium levels fall. This causes the plasma membrane to become unstable, and then things like myoglobin and toxins leak out and get into the kidneys. Like I said, can have detrimental effects. The NSAIDs, which stands for non-steroidal anti-inflammatory drugs, has been shown to have a significant relationship with hyponatremia, in the fact that NSAIDs are a risk factor of hyponatremia, and these are things like Advil and Aleve, and they can cause you to drink more water as well as decrease our sodium serum concentrations. So in conclusion, hyponatremia is a misunderstood and bad thing, and it's sodium serum levels underneath 135. And overall, there should be prevention and education as to what to do, and doctors and people should know when you have to go to the hospital and how to get treated for it.
Good, 20